Hi, welcome everyone. I'm Jane, co-founder of OBGYNs for Sustainable Future, and I'm so excited to have this expert with us today, Dr. Preeti Jaggi.
Jaggi.
Jaggi. And she is incredible. I heard her speak on another forum, and I was like, I have to understand a little bit more about her area of expertise. So, as background, she is a pediatric researcher in Atlanta. She's associate professor in the Department of Pediatrics at Emory University School of Medicine and director of antimicrobial stewardship at Children's Healthcare of Atlanta. And when I heard her speak, I heard her talking about some of the ways that we can make changes in the way that we dispense medication. But I also wanted to understand better her knowledge about the intersection of the pediatric population and sustainability and climate change. So, welcome.
Thank you so much for having me. I appreciate it.
Yeah. So you've authored a lot of publications focusing on healthcare sustainability, antimicrobial stewardship, and the intersection of climate change and pediatric health. Can you give us just a quick little background on how or why you got interested in this? Was it a patient story? Was it your own story?
Yes, so I have always been really drawn towards environmental stewardship, even when I was in high school. I remember watching an Earth Day special on TV with Bette Midler on there, and I was always really kind of concerned about this and sort of put it in my back burner. I like to garden and do things outside and went into medicine, and I became an infectious disease doctor. So I'm a pediatric infectious disease doctor. And I think in infectious disease, we're really think about this concept of one health a lot, which is that, the health of animals and humans are integrally tied together and also dependent on shared ecosystems. So, in ID medicine, we always ask about, have you been swimming in a river, or have you been around an animal? So we really just kind of always are thinking about that. So I got into antibiotic stewardship, which is also something that is relatively new. It started in 1996 was when the term was first printed, antibiotic stewardship. But the idea has been kind of evolving that if we keep using antibiotics indiscriminately, we're going to have a lot of resistance and they're not going to work for our patients. And we know that, antibiotics that we use in one person can actually affect the health of another person because the waste can get into the environment and that can lead to resistance. And so we started, in earnest in the 2000s, having more antibiotic stewardship activities going on. And then I became the antibiotic stewardship director. And I remember at that time people asking me about, would you rather be the fellowship director, fellowship program director, or do antibiotic stewardship? And I was like, I want to do stewardship because that is to me makes sense with what I am kind of interested in. And so that's kind of the path that I went on. And now I just sort of see how we could use stewardship of antibiotics as sort of how we've done a lot of good things in this area. And now, wow, we can sort of expand this. And that can be sustainability and thinking about more resources and how to use our resources wisely. And now it just gives me a lot of joy to think about that because that means that I can integrate something that I've been interested in since I was a high school student into my daily work.
Yeah. So one of the articles that I was reading that you published was about comparing liquid antibiotic to oral for children. And so could you tell us from an ID perspective, are there any benefits to either modality? And if so, why should we choose one over the other?
Great question. So, part of the reason that I started thinking about this is because I've tried to, decrease plastic coming in my house, and I noted that a lot of the when you carry a liquid, you got to get a lot of extra plastic to hold a liquid versus a solid like a bar of soap versus liquid soap. And then it made me think about amoxicillin because amoxicillin is the most prescribed antibiotic to children, and at least 10 million doses each year are given to children, and a lot
Wow.
of it's liquid. So in our hospital, it's about 60% of it's given liquid. And we also give a lot of Motrin and Tylenol to our children that's liquid as well. And I mean, when my kids were little, I was giving them liquid.
Right, right.
And so it's just sort of something that we just do. But there are some chewable tablet preparations, and when we give a liquid dose to a patient, we need to also give a dose dispensing device because in the past there have been dosing errors. So we
Oh,
have to give a dose dispensing device when we give a liquid so the parent can accurately give the right amount of drug. And so I just did a question to community pharmacists about like tell us like do you waste the liquid the liquid amoxicillin comes in certain amounts so you have to stay you can't you have to a lot of times give extra and then we know that small amounts might get into the environment which is probably not good for resistance so I did a little survey of community pharmacists, and they have a lot to say. They had a lot to say about that some is wasted. They also don't like we have a lot of electronic medical record prescribing, which says 40 per kilo per day divided BID, so it's 20 per kilo per dose, and that like it could be really specific. So you end up prescribing like 7.2 mLs twice a day. So what parent is going to be able to figure out 7.2 mLs? That's
right.
so confusing. They didn't like that. They didn't like that sometimes we add extra 10 cc's because it might spill.
Oh,
And so that's what a lot of pediatricians do. And so we just started thinking about, hey, we have a dose range that we can give to children. So why don't we have what we kind of consider stair step dosing? So you're between this and this and this weight, you could use this. And so we just made one for chewable amoxicillin tablets. There are still some issues with that in the sense that only one provider makes chewable tablets for amoxicillin, where multiple providers make liquid amoxicillin. But we're working on just trying to get this out in the literature because if the norm was to use a chewable tablet, which doesn't need to be refrigerated, which doesn't
yeah,
need to be syringed for the dose dispensing device,
right.
it could just it would just be a simple change that could actually save a lot of plastic and potentially a lot of extra dosing that's gone into the sink, for instance, because
Yeah.
they're giving it extra. And so in stewardship, we're saying, oh wow, pneumonia we can treat with 5 days now instead of 10 days for
Oh, I saw that too. Yeah.
pneumonia. But then if we give extra to the patient, that's a little confusing for them because we have to with a liquid amoxicillin. So I just think there's just ways, and then you don't have to refrigerate it. If somebody's traveling, they can put it in their bag. So there's just a lot of, I think, benefits of that. But we do have to make sure that it's available. And that
Now, is there an age where you absolutely recommend liquid? Like for toddlers, are they better at taking liquids than a chewable?
So it's been studied down to 2 years of age.
Okay.
The biggest thing is you don't want the child to aspirate.
Right.
You could you could crush it up and then put it in
Crush
a
it. Yeah.
something and put you could do that, but I think it's just probably easier to think about it as 2 and above, 2 years of age and above, and then you have to also think about the if the child is developmentally normal, which
Yeah, exactly. Yeah, that they manage it.
you don't want to
Um,
aspirate it.
In all of your work, have you come across a justification for the blister pack? Because when you mentioned chewable, it made me remember that I took some chewable Benadryl that was in my closet the other night. I got a really bad case of poison ivy. And I'm telling you, it worked amazing. But anytime I pick up a blister pack, I'm like, but why?
Why
Can you know why we have blister packs?
That's a great question. I don't know where it came from. I know that we're just in the process of trying to stock some of our Omnicell, which is like our local where the nurses can go get the drug with chewable Motrin, and we can't put a bottle of Motrin in the Omnicell and then they just dump out whatever they need. You can't do that in the hospital. You have to put it in a blister pack, which means
Okay.
a bit of extra pharmacy work. I don't know where that rule came from.
Yeah, because sometimes I think about us, taking a medication out of a blister pack, which obviously there's usually, six uh, pills in a blister pack. And then sometimes we're taking the pill out of the blister pack and then we're putting it into like a little plastic medicine cup. And
Yeah,
it's like so much plastic for one pill.
so much plastic for one pill. I do think maybe in the hospital setting, it's also to know what the drug is so you don't get confused about what the pill is so that like it's listed. And I will say that if I looked at the Motrin blister pack versus the liquid, and it was so much less plastic by weight because it's just a little bit of plastic on the bottom and then a foil at the top. So
Okay, yeah.
actually much less than a bottle.
Yeah.
So I think but I think maybe some of it, I actually haven't asked anybody why is this, but I know it's a regulation,
Yeah, yeah.
a lot of regulation. So
I'm curious if you have looked at neonatal or children in the PICU's exposure to the phthalates in all of the medical tubing and devices.
I haven't looked into that. I think that's a fascinating untapped area. I mean, a neonate has like 60 cc's per kilo of body weight of blood in their body. So like you think that's got to be a lot per your blood volume, like when you have multiple lines and things like that. I have not looked at that. I don't know how to measure those things at this point. But that is something that I think is really, really interesting. It is, there's so much work on stewardship on the microbiome and thinking like, are we messing up the microbiome in pediatric patients and then they get autoimmune illness later? But I
Oh, yeah.
that's
Yeah.
one aspect, but this is another aspect that I'm not sure has really been looked at very much. So I actually don't even know how to measure those things myself because I'm not a toxicologist, but that would be really, really interesting to look at.
Yeah, I have seen some studies, and there definitely can be supraphysiologic levels of phthalates being measured in NICU infants. And one study I looked at said that the enteric um, tubing
Hmm.
was had delivered the highest levels of phthalates. Um, it's interesting. I just finished a book about PFAS. It's called They Poisoned the World. And one of the people in the story, she mixes in history with individual stories of people. And it was a town in New York that had a Teflon manufacturing site, and this woman, she got pregnant, and she had already known that her well was contaminated with PFAS. And she actually contemplated, should she continue the pregnancy because she knew how high the levels were. Nothing had been fixed. And over the course of the book, we learned that they did, where they were able to compensate her because it takes, a lot of money, tens of thousands of dollars to filter out, your whole house for PFAS. And then she did end up having the child, but then she had the infant's PFAS levels measured, and they were like 5 times the acceptable level. And so we know that a lot of uh, medical devices have PFAS in them as well. And I think it's kind of the situation where we really haven't even studied it. But if we did, we might not, we might be horrified by the results.
Mhm. Oh my gosh. And I think each route, like, so I think a lot about IV to oral conversion, like trying to give him the medicines by mouth to a patient. That's what we do a lot because that's a lot of plastic, a lot of time, a lot of all the things. I do oftentimes say, like, if they have an NG, you could put, there's even some studies in bronchiolitis and infants with bronchiolitis.
Yeah.
If they can't, like, should you do an IV or should you do an NG? To feed the baby because they lose the IVs quite a bit and they need hydration because they can't drink. But I just wonder about like all these things. Everything's got some potential harms. Best to just try not to have them hospitalized for bronchiolitis. Like try to keep these babies out of the hospital. Probably the best thing to do. But um, that's an interesting like it's hard for me to think about all these things because I'm like, well, is putting an NG better than putting an IV in the blood? Is I guess my
Yeah.
thought.
Yeah. What was I saw a study the other day showing that, one 250 milliliter IV bag delivered something like 15,000 plastic particles.
Yeah. We're doing a lot of judicious use of fluids in our hospital because we had a fluid shortage, you know, from a storm that's exacerbated by climate change. So that we are actually doing a lot better in our hospital, which has made me really, really happy. And we haven't had any more acute kidney injury. We are doing it seems to be very safe for the patients, and we're just, trying to eliminate unnecessary use. And then so I think that's been a really, really good thing. Every time there's a shortage, there's an opportunity
That's right. That's
optimize
great.
how that is being used. We've done it with blood culture bottles. We had shortage with blood culture bottles. We've done it with fluids. Now, drugs all the time get antibiotic shortages because they're generic drugs, there's shortages. So every time we do that, there's an opportunity to, and then actually, if you think about minimizing treatment durations, you're also minimizing all this exposure.
Yeah, no, that's true.
So
Has your role as the co-founder of the Sustainable ID subcommittee within the Pediatric Infectious Disease Society, have you guys put together like a checklist of recommendations for pediatricians, or where are you guys at with your initiatives?
we did a supplement with a series of 6 articles that are co-published in the Journal of Pediatric Infectious Disease Society and Open Forum of Infectious Diseases. So a lot of our subspecialty is um, inpatient focused. So we talk about pharmacy waste, infection prevention practices. We do have a very nice one that a couple people did that are fellows that did on outpatient stewardship. So I think there are a lot of really good information. There's a lot of really good information there. I'd like to see us do more. A lot of it has to do with infection prevention practices in the outpatient setting, and then also advising pediatricians how to talk to families about it. Um, that I haven't kind of gotten into. I'd like to do that. I think a lot of my efforts naturally focus on inpatient efforts because that's my lived experience every day. But I do think that we can also collaborate with other pediatricians that are not ID too. There's some really good work done by a couple people that are working on air pollution, climate change. But I do kind of wonder now, like maybe we do need a specific, like how do you avoid plastics? Giving plastic
Yeah.
exposing your child to plastics. I think that's going to be another area, which are all under the umbrella of environmental stewardship. Um,
Are there groups of physicians within the American Academy of Pediatrics that are looking at how to advise parents about how to decrease plastic exposure?
that's a good question. I know there's one on pollution. I know there's one on pollution, climate change. I'm not sure if there's one on plastics specifically. There might be. I just don't know of that group yet. But I think that's an area that we can start because I think the other thing too is that parents, when they start demanding products that have less plastic, I think you'll start seeing some things change in in the products that they buy. So there's a lot of reasons to do this to try to help them decrease their baby's exposure to plastic, but also to move the needle in how industry is packaging their products.
Yeah. So, couple things. So, we at the Physician and Scientists Network for Plastics and Health, PSNAP,
Yep.
we're trying to put together like a one pager, a front to back, that basically kind of explains plastic and EDCs, endocrine disrupting chemicals, for patients, which it's actually having put the pamphlet together. This is very hard. I mean, it's a difficult topic even for physicians to understand, but then to try to explain it to prospective parents or new parents, I found myself really struggling with how to make a really complex topic straightforward. So we do that on the front page, and then on the back page, we have like 10 things that you can do as a pregnant woman or as a new parent to try to decrease plastic exposure. I wonder if this would be, I know the AAP has a great website about plastics and endocrine disrupting chemicals. But I wonder if they have something like that in the works as well.
I put something in the chat just now, just it's an AAP document. It has some information about decreasing exposure too. So maybe you could be a little more patient friendly. But
Oh yeah, I have seen that. Yeah. Yeah. It's hard, right? It's really hard to talk about this subject.
I think videos or some other marketing techniques too could be something, but there is an environmental health group, so we could try to see if we can make that more accessible to families. I think New England Journal also has done some really nice work too. They have a really nice video about how climate change affects children's health, but I also wonder about using them as a because they produce some really nice videos, but it can be a little bit more digestible for families.
Yeah. I give a lot of talks and I gave one where I work, the University of Rochester and Rochester Institute of Technology have a grant to study plastics, microplastics in the waterways here. And so we had a symposium a couple weeks ago, and I one of the slides is that study showing that comparing adult to infant feces, that infants had 10 times the amount of plastics as adults. And a couple people in the audience were really disturbed. I think that sometimes people aren't aware that the physiology of children makes them more susceptible to these exposures. Can you talk a little bit about that?
They're also putting things in their mouth so much. I mean, this is why we see children with non-tuberculous mycobacterial lymph node infections, and it's the toddler who constantly is putting stuff in their mouth, right? Like so you think about how much, and you're giving them a plastic toy oftentimes, and they put it in their mouth. So there's just so much, and then their bottles are plastic, and I mean, that is just I think just the amount of time that they're putting their food in their mouth. So, and that's your youngest patient who's doing that the most, and then they're going to probably have the most exposure. And that seems to be the age where we give them the most plastic stuff.
Yeah, yeah, you're right. The other
So,
thing that I've seen is, and my children are 17 now, but now a lot of food packaging is in these little plastic pouches, where again there's more plastic exposure because you've got smaller amounts of food surrounded by plastic, but multiple times of exposure to that. Is that something you talk to your patients about?
I do talk about trying to avoid, using glass, using stainless steel and things like that. The problem that I find is that young parents are so busy that I
Right.
want to see if we can do a couple of things. I think toys, I think we should be telling them about toys as I think about actually as I'm talking to you, because toys are put in their mouth quite a bit, and we are buying these plastic toys for these kids to put in their mouth. And I think that is really important. I think there's some, simple things that you can do, but I do try to not overwhelm families too, because
I know, right?
it's like they're like trying to just survive, young days when you've got young kids. So yeah, that is tough. But maybe just giving them one thing or two things to do where they could actually change it. Um, you know, Tupperware, like that, those
Yeah,
kind of things too.
that's easy. Yeah.
And those kinds of things I really do talk about.
Are you currently working on any QI studies, or do you have your fellows research that you want to share? Anything that's like not yet published, but you're excited about?
Yeah, we're putting in the Motrin chewable tablets in our hospital. So we're piloting on that on one floor. And then, we estimated we could save like 382 kilograms of plastic waste if we get this to work in our hospital, where we replace the liquid Motrin, Tylenol, and Amox with chewable. So we're going to try it, and then we can also ask parents about how it goes because they're in our system. So then we'll try and keep that going. A couple of my hospitals are really, really excited about that. I basically try to use some kind of sustainability lens on all of my stewardship projects. So like we're doing a project about avoiding unnecessary vancomycin in the pediatric ICU for certain types of patients. And so we've reduced that a lot. And so we're measuring nursing time saved, plastic waste saved, the cost savings, all of those things. So we're just tying it in with everything that I'm doing from a from an antibiotic stewardship standpoint. I just try to add some kind of climate lens on it. And it's really, I think my providers actually are like, wow, that's cool. Like if I can tell you you can be a climate hero by doing antibiotic stewardship, all of a sudden we are more allied than them thinking that I'm the antibiotic police.
Right. No, that you're like firing on all cylinders there. Do you find that you get a lot of support from your administration for this work? Are they excited to be able to point to you as a national expert?
Um, I guess on one hand, I feel like I'd like them to do more, and it's been hard to get a multidisciplinary sustainability group off the ground. We are just starting to do that after, years. But I think they're happy to point to the things that I'm doing and the things that I'm working on. I'm giving grand rounds in a few days at my institution. Um, I think that the thing that motivates hospital administrator is saving money.
Oh, yeah. So do you always put a cost analysis then into your studies in order that you can, uh, if it comes up positive, you can say that?
Because cost savings is a big deal. We're doing a couple of things that we're just working on right now. Is one, we use throwaway pillows, so we throw away a bunch
Oh,
of.
I hate throwaway pillows.
We're working on going to reusable pillows, which you do have to think about from an infection prevention standpoint. And then that's supposed to be saving us $200,000 to $500,000 a year. We have a
Wow.
lot of work on antibiotic waste that we're reducing by just smarter ordering practices. And so I told them, like, if I can get you, I can save you $1 million a year. I really I can
Yay.
save all that on just the pillows. I do think I can say we're working on using gloves wisely, because that's been worked on in other centers. I think we can get to those kinds of, and once you start getting, if you say to your administrator, you can save $1 million a year, they'll listen to you.
Yeah. Well, what would be nice, what I would love to see is that if those of us who are willing to do the work, research, um, uh, put best practices together, that if we do end up saving money, that then the administration would say, okay, well, 10% of the savings could go back into physician development or APP education, so that we could basically kind of circular economy our own work so that it has the potential to grow beyond, just us. And then, we could develop a center for sustainable, you know what I'm saying? Like so that the work that you're doing gets even bigger.
I just talked to some of our administrators and I said, hey, if we save $1 million, can we say that we want some FTE next year? I mean,
Exactly.
my FTE could be a third person, like, to help me, like, get the monitoring and all that stuff. So yeah, that's what I actually think you should go in the beginning and say, if this happens, will you do this? And then
Yeah, put it in writing.
put it in writing. Yes. So I mean it is fun and it's creative actually, which is kind of fun. Like I like the creative aspect of all of this. It's trying to, and I do think it's a little contagious. I work with pharmacy a lot, so they were talking about, hey, like this vial of daptomycin, we don't need it to be so big in children. Like my anesthesiologists are telling me, like, they waste a lot of drugs because the baby's so small and they have like adult sized vials, so they want to advocate to get smaller. In that sense, they want smaller vials so they don't waste so much drug.
Yeah.
Or can you use like ways to divide up things? So people start thinking about this, and that's really fun. That's really fun.
Yeah. Do you work at all with OBGYN colleagues on these topics at Emory?
I have not, because ours is a children's hospital. It's not a birth hospital.
Oh, yeah.
Not done that, and I would like to, actually. I would like to do that. I think that also that's probably the time you could talk to patients about avoiding plastics later too. It's
Yeah.
hard in a pediatric office when you're doing a lot of preventative counseling, maybe also for you guys.
I was like,
See
yeah.
them frequently though, which is really nice. You see
Yeah.
them more frequently than we see the baby.
No, that's so true. That's so
That
true.
first month. So I do think that, so there's never enough time, right? We never have enough time to do anything, but it could be a really cool partnership though. Maybe we could partner AAP too with OBGYN groups.
Yeah, no, I think it's a real natural relationship, especially for, preconception through pregnancy and then early infancy that, we have some more continuity of conversations about sustainability and environmental exposures, that would be really great. So for our audience, if they are interested in thinking about either doing some, a smaller research study at their institution, do you have any like easy research questions that maybe they could start with, or how to initiate the conversations with pharmacy and get them to kind of do this together? What's your advice for someone that might want to do that?
I would, you're always going to have infection prevention at your hospitals and an antibiotic stewardship program. Like they have to exist. So you can approach them and say, hey, I'm interested in reducing, waste or whatever you're interested in. Start small and see if you could partner with them because they could be a really good resource. And I think they could actually, many, many times it is a very synergistic, like their goals will be aligned with your goals, especially
Yeah.
with antibiotic stewardship group. They will be thrilled. Like nobody comes to me and asks me. Like I usually reach out to people to say, "Hey, could we do this project?" So I would be thrilled if somebody said, "Hey, I want to, figure out a way to reduce waste that has some aspect with antibiotic stewardship." That'd be great. Um, I think start small. For the outpatient providers, we're working on our sustainable ID website, so we'll have some information for outpatient providers as well. And then a lot of things really intersect with infection prevention. Like we have to make sure our patients are safe, and that also generates waste. So it's a little bit of a tug of war in these like you don't want to have environmental waste, but you do want to prevent infection, and it can be hard to do both. So we're gonna try and get some like information out there for people to use in their outpatient offices, thinking about low hanging fruit from infection prevention standpoint, because there are some things that are really hard and there's some things that are a little easier. So you want to make sure you start out with the easier stuff. Don't start out with the ones that are going to be so difficult that you're going to get frustrated.
Yeah. What would be an example of a easy infection prevention initiative?
I think using gloves wisely is low hanging fruit.
Okay.
I think there are a couple of papers about the on the exam table. Like if you are wiping down the exam table in an outpatient setting, you don't really need the paper. You probably don't need to purchase that paper. There's a
Mm.
couple papers about that. We are going to work on the pillows in our hospital. We also have the blood pressure cuffs. So the blood pressure cuffs, we throw away one blood pressure cuff per emergency department patient. So
Oh, wow. Okay. Yeah.
So when you're thinking about infection prevention practices, there's the Spalding classification. The low-hanging fruit, to me, the lower risk is when you have intact skin and intact, you're not disrupting a mucous membrane, you're not having bodily fluid
Right.
so those are the things where you might think about reusable items where you have to figure out how to clean it. And there are so many things that in cleaning that because you have to follow the manufacturer's instruction for use, and that can be very confusing. But when you're dealing with intact skin and intact no mucous membrane contact, that's going to be easier things to think about. In the infectious disease world, in the infection prevention world, some hospitals are doing contact precautions for things like MRSA infection, MRSA infected patients, and some are not. So we are trying to use those gowns and gloves more judiciously. And
Interesting.
that's a little bit of a debate right now. But if your hospital is doing something around that, you can get in on that. But to me, the gloves is just such low hanging fruit because so many times I see people using gloves and they don't need it.
Yeah. Yeah. Um, that's me too. I do not like to conduct a physical exam with gloves on. It feels like
Mhm.
awkward. But I feel old school. I feel like the medical students are trained to like gloves on immediately. They hit the room, they got to get the gloves on. So
I know. And actually, hand hygiene can improve when you don't use them on a
exactly.
that's
Exactly.
that's a win-win. So that's a win-win. So anything that can, improve patient care or decrease workload, environmental impact, and cost savings, that's like to me the golden area where you just want to start.
Okay. I love that. Well, thank you so much for your time today. Really appreciate lots of wisdom, lots of ideas. I hope this video gets lots of views and have a great week.
Thank you so much. Great to meet you.
Bye.